This is the first presentation in an introductory series on the topic of musculoskeletal radiography. The series will provide a foundation for our remaining musculoskeletal lectures, and you can apply what we learned to both the appendicular and axial skeleton. The intent of this presentation is to provide a description of the examination technique and an introduction to interpretive principles of the musculoskeletal system in carnivores and ungulates. Radiographs of the musculoskeletal system can be obtained in awake or sedated patients. However, sedation is often necessary for proper positioning of some specific regions or obtaining specific views, and appropriate sedation will also help manipulation when patients are painful and or anxious. The only other preparation is to clean the area of superficial debris, and if we're radiographing the foot of horses, to pack the sole. We always want to obtain at least orthogonal views, our views at 90 degrees, and we should always center and collimate to the area of interest. When we are radiographing a long bone, then we should be sure to include the joint above and the joint below. Standard views in carnivores are usually just the orthogonal views, but remember that standard views in ungulates most often include off-angle views as well. And then for both the small and large animal patient, supplemental views we might obtain could include flexed or extended and stress views. And then certainly when we're looking at the equine foot, we have our specialized views and then oftentimes obtain skyline views of the carpus and potentially the tarsus. On this slide, I have examples of positioning on the left of a joint. So notice we want to center and collimate on this dog's tarsus on our two orthogonal views. On the right side of the slide are radiographs of long bones, or the radius and the ulna. And again, we want to center and collimate on the area of interest, but we want to include the elbow and the carpus in our radius and ulna, so joint above and joint below. Remember that for displaying the lateral view, we have proximal at the top, distal at the bottom, and then cranial or dorsal to the left of the image. On the DP view, remember there's not really a convention, and you can display medial or lateral as you like, but proximal will still be at the top and distal will be at the bottom. When we start to think about some interpretive principles, I'm going to use the horse as the example on this slide. The first thing is that you should always arrange and evaluate your images in a consistent manner. So if you have two images, maybe you always have the lateral and then the DP. In this horse, remember this is the tarsus we are evaluating. We have 4 views. So typically I will start with my kind of standard orthogonal views, so the lateral and the DP, and then we'll follow by displaying our off-angle views. And then if we have any supplemental views, which might be flexed or extended, skyline, stress views, I will evaluate those next. We always want to start with evaluating the diagnostic quality of our study. So do we have appropriate positioning? Do we have appropriate exposure, which usually means that we can evaluate both the osseous structures as well as the soft tissue structures. And then make sure that we have all necessary views. So in this tarsus, our standard views are 4 in the horse, but maybe as we're evaluating it, we decide we actually need an additional off-angle view or a flexed view. So then we'll be sure to obtain those as well. After that, we need to always review in a systematic or organized fashion. And while we're evaluating in that systematic or organized fashion, we need to be considering that we have to recognize alterations in what is normal. And so because our interpretation is based upon the knowledge of normal anatomy, it's going to be important for you to review using, your previous notes, websites, textbooks, whatever you use as your foundation for normal, to be able to now recognize as we move into abnormal what is abnormal. And we need to consider our radiographic or Rankin signs as we're reviewing, which include opacity, size, shape, location or distribution, number, and margination. Now, there are times in practice where perhaps it is a variation of normal, or you have a young patient that you're having a hard time finding what all the normal physes look like. Remember, I do have some presentations from your normal anatomy for that. But in practice, you might want to consider just obtaining radiographs of the unaffected limb so that you can compare. So this slide just gives you a sample of an organized approach to evaluation. This is what I tend to use. This is a lateral view of a dog tibia fibula, so again, including the proximal joint and the distal joint. And I like to start out just considering alignment. So alignment may be alignment at the joints, or if there's a fracture, it might be alignment related to that. Then I actually like to look at the soft tissues next, because I think that sometimes soft tissue changes will help us to identify where the actual problem is. And when I'm evaluating any of these, I usually start at the top of the limb and work my way down to the bottom of the limb, or the distal part of the limb. So I'm just evaluating all the soft tissues that might be outside of the joint, and then soft tissues around and associated with the joint. After that, I move into the bone, and we need to consider that there are different parts of the bone. So I start with the cortex proximally here, since that's where we're in a mid-diaphysis of the femur. And remember that the cortex has an outer or periosteal surface as well as an inner or endosteal surface. And then we also have the associated medullary cavity that we will evaluate. As I move down distally toward a joint, then I am also considering the periarticular region, so the margins around the joint, as well as the articular surfaces. So the articular surfaces have cartilage that are going to be soft tissue, so they're going to look like the joint soft tissues, but I can look at the subchondral bone here, and that subchondral bone is kind of the thin, more dense or more opaque plate of bone that is at the surfaces of the joints. And then I'll just continue working my way down. Another approach that some people apply is the ABCDs of bone evaluation. The A stands for alignment, so that would be overall alignment. The B stands for bone, so you would use the same sort of evaluation as we saw in the previous slide. But then C stands specifically for cartilage, so it will make you think specifically about the joint surfaces, subchondral bone and cartilage. And then D would be for any devices, so any orthopedic implants that are present. And then S would be soft tissue, so ending up with the soft tissue in this case. And then my last part of evaluation is doing a final check. So I've already hopefully identified all of the abnormalities using a systematic evaluation, but when the patient came into me and I did a history and then a physical exam or had any laboratory work, I had already thought about some differentials, and then also based on signalement and knowledge, this patient might be at risk for certain things. So my final check is, did I look for what this patient might have been at risk for? And we'll learn about some of that in subsequent lectures. And did I rule in or rule out my initial concerns? Once I have done all of my findings and been very good about describing them in detail, then we're going to conclude on all of those identified abnormalities. Certainly we have to determine importance, but then for the important ones especially, we need to develop differentials for those results. And we discussed this approach with abdominal imaging. So similarly, we want to start with that gamut approach, which is considering the whole range of anything, and then using our age, our gender, our species, our breed, clinical history, and exam findings, we're going to refine that list of anything to a list of probable diagnoses, and then we need to rank order that final list in an order of probability, and remember to consider your pathophysiology and pathoanatomy. There are some additional imaging studies that can be beneficial, and the slide lists those, and I'm going to show you some examples. So in practice, you could use some contrast procedures. To the left of the slide is an arthrogram, and what we will do for an arthrogram is we will inject iodinated contrast into a joint to outline the joint cavity as well as to show us cartilage. In this shoulder of this dog, the shoulder joint has been injected with iodinated contrast. So the contrast is the radiopaque material that is within the joint cavity. And then if you notice, between the bone and the joint cavity is a thin radiolucent kind of filling defect. That's actually the cartilage. And then in the dog, the shoulder joint actually is communicating with the bicipital bursa, and so now we can actually see contrast in the bursa and outline the biceps tendon. These round filling defects are actually air bubbles that were mistakenly injected. On the right of the slide is another study, which is a fistulogram, and this is when we inject iodinated contrast into a draining tract. And so in this patient, we have the digits here. The iodinated contrast was injected into a draining tract within the toe pad here, and what we can see when we do this is that this draining tract actually communicates with this distal interphalangeal joint of this digit, and so that might be important to know for therapy. Ultrasonography is a very beneficial additional imaging study to image tendons, ligaments, soft tissues, and bones. It can also be helpful to guide sampling. In this example, I have a lateral shoulder of a dog that showed a lesion at the caudal aspect of the humeral head, and on ultrasound we can see that the lesion is predominantly a soft tissue lesion, but it is causing lysis of the bone. So ultrasound is going to be very good for evaluating the soft tissues. Bone is going to cause the acoustic shadowing to interfere with imaging bone, but we can still get some information. Certainly, ultrasound is very often applied in the horse, but can be applied in the dog and other patients as well. Both CT and MRI can be very useful for imaging the musculoskeletal system. CT is very good for bone and moderately good for soft tissue, whereas MRI is very good for soft tissue and is moderately good for bone. So depending upon the goals of our study will help us to decide which of these advanced imaging techniques to use. This is an example of a dog that presented with a draining tract in the kind of metatarsal region. This is a sagittal slice through the metatarsus, and in this is a T1 weighted sequence with contrast. These are the pads that are really bright here, but then this is bright contrast that is outlining this dark area or hypointense area, which is actually a stick. And then in a next sagittal slice, we can actually see contrast outlining the draining tract, which is why the patient was presenting. So now we know he has a stick that we can go and remove. A final additional imaging study that can actually provide imaging of physiology, most of the other studies just show us morphology, is nuclear scintigraphy. And this is when we take a radioactive substance, inject it intravenously into the patient, and then that substance actually evaluates for osteoblastic activity, which occurs in varying degrees even during osteolytic disorders. This is used a lot in the equine athlete, but is also used in small animals. So this is an example of a horse that had lameness that was difficult to localize. This is a hip. This is the right hip of this horse, and this is the left hip. So if we compare the right to the left, there is this this activity here that is within the area of the acetabulum. These are dorsal images where we have the left hip and the right hip, and again there is this increased activity in the area of the right acetabulum, and on radiographs fracture was identified, and this was difficult to localize without the use of this procedure. You may be interested in learning some more information just about the examination technique and interpretive principles, so you can consult the reading that I have given you here.